Thanks. Can everyone hear me? So if for some reason the mic moves away from me during the talk and you can't hear me, please just raise your hand and tell me to speak up. I'm just going to start my timer here. I'm going to first off start by apologizing. I have a lot of material. I'm the eager beager because I have 2 kids with autism, like many of you guys have a kid on the spectrum, and I just want to give you guys the most possible amount of information to try and help your children have a chance to have a form of communication, because I think that's so critical in life. So this is just my disclaimer. Please recognize that I am not giving medical advice. Any of the treatments that I discuss during this talk, you should discuss with your practitioner or provider, because even vitamin supplementation can have side effects, and it's better to work with somebody directly. So my question, when my child was, this picture was taken, I think when he was 2.5, we'd moved to Virginia. We'd spent a lot of money for a year of ABA, intensive speech, OT, and physical therapy, and my kid still wasn't talking, and I didn't understand why he wasn't, and yet I had other friends who had done the same thing as me, and their kids were talking. What was wrong with my child? So what is autism? So autism is defined by the DSM-5 as persistent deficits in social communication and social interaction, restrictive, repetitive patterns of behavior, interests, and activities. This is based on observation, and it's subjective. There are no blood or biological tests for diagnosing autism. Autism is a spectrum disorder. Some children are affected mildly, while others are severely affected. Some are born with it, and some regress at different ages. So the autism diagnosis tells us little about the possible contributing factors and causes of autism. So this is a study done in 2018 of 4 to 8-year-olds where they found 95% of these children had at least one co-occurring condition or symptom, and 50% had 4 to 5 comorbid conditions. My children have like 8 or 9. And one of the things that we discovered with my son, who wasn't speaking when he was 2.5, that when we saw a practitioner, he had hypothyroidism. He had no symptoms of hypothyroidism. When you think of hypothyroidism, you think of fat female and 40. Well, this kid was like failure to thrive and scrawny. But the practitioner told me that about 20% of the kids on the spectrum in his practice had hypothyroidism, and sure enough, my kid had it. And so I tracked my second child for it, and he developed it when he was about 3.5. So just because your child doesn't have hypothyroidism at the first visit, it's something that should be periodically maybe screened, once a year or so in our patient population, just because the incidence is so high. So what are some of the comorbid conditions associated with autism? Gastrointestinal is huge. I see a lot of patients with constipation and diarrhea. I see a lot of patients with low cholesterol, which can cause irritability. I see a lot of metabolic problems, mitochondrial disease and dysfunction. I see a lot of seizures, about 20, well, I'd say the percentage of seizures is higher than 13 to 26% in this particular study. ADHD is very common in this patient population. Allergies is another big component that we see in these kids. My older son, I didn't even realize all of the seasonal allergies he had because he didn't have the traditional symptoms that you see, with the runny nose and watery eyes, until we tested him this past year with skin testing, where they, inject the antigen under the skin, and he was highly allergic. And so that might explain why sometimes his symptoms are worse during certain seasons of the year. And we do see that in our patient population. Spring and fall seem to be a bad time for a lot of these kids. They tend to regress. We also see food allergies, and then as well as endocrine disorders like hypothyroidism, which I mentioned earlier, and then many psychiatric issues such as anxiety, OCD. So several metabolic abnormalities have been reported to contribute to a potentially reversible form of autism, and that's called cerebral folate deficiency. How many of you have heard of that in this room? Okay. This is like, I feel like it should be front page news, and it's something I'll talk about through this talk because it's a huge issue in this patient population and it is treatable. And the goal is to try and identify these things as young as possible and then treat them. And testing can be done through biomarkers, laboratory tests. So I believe autism has a clear biological basis with features of known medical disorders. In my opinion, it is not just a psychiatric disorder. So this is the developmental trajectories that you see that characterize children with autism that are receiving traditional standard therapy, ABA, OT, speech. So, oops, sorry. So as you can see, you have your low-functioning kids. This was the trajectory of my older son. And then some kids will just, like probably my friends' kids who all of a sudden just had these great benefits from ABA and just, they seem to have great progress. But as you can see here, as they get older, the gap between them and their peers widens greatly. So they look worse and worse as they get older. And so if you do nothing except for standard therapies in a low-functioning child, you may not get as much improvement. So that's why we're talking about this today. So this was my kids' trajectories. This is my son Isaiah now, and then my younger son Joshua. So Isaiah was pretty much not making any progress, and then as we started finding out that he had hypothyroidism and other problems, his trajectory improved. Now, no, he's not, recovered from autism, but he's 1,000 times better than he was when he was younger. I never thought on this side of eternity I would know what his favorite color was or his favorite, a music artist. I didn't know that he could tell me about the dreams that he has, and that, that one day he would tell me what he wanted to do as an adult. Those things are possible, and those things have come over time with him. He has not been the easy kid to treat. I feel like God gave me one kid on the lower end of the functioning and one kid on the higher end of the functioning, so I would understand parents from both sides. Because I'll have a lot of people look at my younger son, who's very high functioning, and say, oh wow, he's great. Like they have no idea what he's like at home. He's great outside, but he has some behavioral issues with me at home. But it's mostly like being a typical teenager. But with my younger son, he was lucky, and he just had this like huge jump, and he's conversational and hasn't stopped talking since about here. Sometimes I wish he would stop talking, and then I remind myself, I paid a lot of money to get him like this. So what are some of the possible causes of speech delay in children with autism? Unfortunately, I had to drop one of the topics because I do have a lot of slides, inflammation, but just keep that in the back of your mind that is one of the issues, is inflammation, especially in different parts of the brain. It's been well studied in kids with autism. Multiple studies have shown inflammation in postmortem studies in children with autism. So we're going to be looking at mitochondrial dysfunction, seizures, and then cerebral folate deficiency today. And this is my younger son. Oops. Okay, so evidence linking oxidative stress, mitochondrial dysfunction, inflammation in the brains of individuals with autism. So there's been a lot of studies on this, and interestingly enough, the brain regions that are found to contain the physiological abnormalities found are very common in the speech and auditory processing areas. And these findings suggest that autism has a clear biological basis with features of known medical disorders. So what are mitochondria? They are the power plant, basically the batteries, in every cell in our body. The mitochondria power our hearts, brains, muscles, our digestive system with energy in the form of ATP. So they basically take the food that we eat, the air that we breathe, that enable us through ATP to walk, run, and speak. And so if your brain parts don't have enough energy for the process of speaking, you may not be speaking. So decreased dysfunction in the mitochondria can cause individuals to have multi-systemic problems. And that's one of the key take-home messages today. So if you have a kid that has multi-systemic issues, meaning like they have constipation, they have seizures, they have attention issues, you may want to think mitochondrial because they are in every cell in the body. That's why there's multiple organ systems involved. So mitochondrial dysfunction and autism. So it's been found to be one of the most common metabolic abnormalities associated with autism. Have any of you heard this before? Okay, good. So the present data, biomarker data, shows that mitochondrial dysfunction, not disorder, is present in 1/3 of children with autism. A small controlled study has suggested that the prevalence of mitochondrial dysfunction, at least measured by lymphocytes in autism, may be as high as 80%. And I'm seeing probably higher levels in children that I'm doing buccal swabs on, which I'll talk about in a minute. So acquired mitochondrial disease in autism. So many children with autism and mitochondrial disease do not have a specific genetic mutation to explain their mitochondrial disorder, raising the possibility that it may be something that's acquired, at least in a subset of children. So some of the potential causes are lowered glutathione concentrations that we find in kids that have things like MTHFR, genetic defects, increased free radical production by mitochondria that are not functioning properly, increased tumor necrosis factor, which is an inflammatory mediator, high glutamate, which is common in kids with autism, environmental toxins. We're exposed to stuff all the time. When I do hair testing, I'm finding lead, uranium, nickel, mercury, all sorts of different things. And propionic acid from Clostridia. So that's an abnormal bacteria that we find in quite a few kids with autism, and that can cause mitochondrial dysfunction, as well as cerebral folate deficiency, which I'll be talking about, and medications. So Risperdal, one of the reasons why it calms kids down is because it's a mitochondrial toxin. Tylenol is really hard on the mitochondria. If your kid has mitochondrial issues, I recommend trying to avoid Tylenol. So brain region-specific mitochondrial electron transport chain complexes. So in studies, they found significantly lower mitochondrial complex activity in the areas of the brain that are specifically associated with speech. So the temporal cortex, they find problems with complex 2, 3, and 4. And so let's see, this is just an example of what the electron transport chain looks like. So you've got complex 1, complex 2, 3, 4, and then 5. And here's where the ATP is produced. And so if there are problems along here, that means the mitochondria aren't producing the energy that those regions of the brain need. So mitochondrial disease dysfunction. It can present at any age. So we've had patients that are adults that were prescribed an antibiotic that is particularly hard on the mitochondria that all of a sudden have developed a mitochondrial disease. It was probably there simmering, and now they've been tipped over the edge and they can't get out of bed. And consider family history. A lot of disorders out there like Alzheimer's and Parkinson's disease are associated with mitochondrial problems. It's very underdiagnosed. There aren't really good, reliable biomarkers. And when I said, think mitochondrial disease or dysfunction when 3 or more organ systems are involved without a unifying diagnosis. So some children have mitochondrial dysfunction, which does not meet the level of mitochondrial disorder. So mitochondrial disorders can be very difficult to recognize clinically because of their diverse symptoms and clinical presentations. So how do you know if your child has mitochondrial dysfunction? So some of the things that you're going to look at: do they have developmental delay, seizures, blindness, muscle weakness, what you call hypotonia? Do they have constipation, cyclical vomiting, exercise intolerance, abnormal reflexes, poor gait, or poor balance? So some more symptoms of mitochondrial disorders: clumsiness, developmental regression, seizures, migraines, GI abnormalities, slow cognitive processing, fatigue, and lethargy. Now let this be said, I have many children on the spectrum that have mitochondrial dysfunction that are hyperactive. So it's not just the couch potato kids. They can still be very active because their mitochondria may not be affected in every organ system of their body. So they can have impaired balance and coordination, sometimes heart issues. I don't really commonly see that in practice, and then oxidative stress. So how do you test for this? So we're going to look at, when I see a patient, we look at the family history, we look at the symptoms, and then we do fasting labs. And then these are some examples of labs that your doctor could order for you. Oftentimes, these labs are normal. And so basically, a lot of times the children's mitochondria are compensating, but when they become sick or they're put under stress, that's when their labs become abnormal, and that's when you see more symptoms. So sometimes we'll repeat the labs later. And then if the testing is positive, sometimes we'll refer them out for muscle biopsy, but usually we just start treatment. So this is a fairly new test that I found particularly helpful because when the blood tests are normal, I'm finding the buccal swab to commonly be abnormal, and so even if they're not sick. And so it measures complex 1, 2, 3, and 4 activity, and as well as citrate synthase. And it has a 84% correlation to the muscle biopsy, which is a surgical procedure that requires anesthesia. And it's the gold standard for diagnosis of mitochondrial disorders. But this can be a very helpful tool, and I use it in a lot of patients now. Now, just to remind you, if you look at the mitochondria here, so the way that the mitochondria get energy, they get energy from glucose, and then they also get energy from fats and carnitine. So remember that, because that's one of the treatments for mitochondrial disorders, is what shuttles the fatty acids into the mitochondria to burn for energy. And then right here, you can see coenzyme Q10, another one of the treatments for mitochondrial disorders. It's what shuttles the electrons down the electron transport chain. So a lot of the different treatments for the mitochondria are actually cofactors that you find in the mitochondria. So how do you interpret a mitoswab report? So in this particular report, you can see that complex 4 activity is 54% out of 100, so that would be in the normal range. However, the complex 1 activity is only 30% out of 100, which is suboptimal. And then you look at the citrate synthase, which is functioning at 164%, which meaning it's way overactive. So the citrate synthase is what tells you how many mitochondria are in the cells. And so in this patient's producing 64% more mitochondria than the average person, and that's to compensate for complex 1 underfunction. The problem is when these cells have reached their maximum capacity to create more mitochondria, when they're faced with stressors such as sickness or toxin exposure, they may regress. And some kids don't even have the ability to make more mitochondria because they have so many underlying issues. So this is a clinical case of a patient I saw. We're going to call him Caleb, but that's not his real name. He presented. He was 4 years old. He had a speech delay. He was incredibly irritable. He didn't want to move. He didn't just wanted to sit there. He had no interest in anything, but just sitting there and just staring off. If they tried to get him to walk or jump, he would cry. And he was way underweight, failure to thrive, and chronically constipated. So the initial labs I did showed, he had 1 genetic SNP on the MTHFR. His vitamin D was a little low, and his acetylcarnitines, which is one of the mitochondrial tests, he had 1 basically marker of mitochondrial dysfunction, but then all the rest of his mitochondrial tests were normal. So do I think this kid has a mitochondrial disorder? I mean, he has all the symptoms. So I went ahead. You can look at the Morovian Criteria. This can be a helpful criteria to kind of tracking to see if your kid might have a mitochondrial disorder. So the way it works is so each of these sections, so under muscular presentation, so this kid had exercise intolerance, so he would get 1 point. Under the CNF presentation, he had developmental delay, so he would get 1 point. And muscle weakness, that was up here. So we got 2 points under the muscular presentation and 1 point under the brain presentation, so that's CNS, so he's up to 3. Then when you go down to multisystemic disease, he has a problem with endocrine growth because his failure to thrive, and then he also had a problem in the GI tract with constipation. So he's at 5 points. So down here, 1, if you have a score of 1, mitochondrial disorder is unlikely. 2 to 4, possible mitochondrial disorder, and 5 to 7, probable mitochondrial disorder. So he kind of fits in that range, and that's before you even do any of the serious like muscle biopsy testing. And so we did a mito swab on him, and it showed that his complex 1 activity was only 23%, and his complex 4 was only 47%, and his citrate synthase was 65%. So even though his mitochondrial complexes weren't working, his mitochondria were not making more mitochondria to compensate, which is why he didn't want to move. When I initially saw him before we did all this, the first thing I added was B12, and that was like, that helped wake him up, and he started interacting with his kids. I later added leucovorin and carnitine, because it takes about 3 months to get the mito swab back, and he began talking and making verbal requests. He even started asking for supplements. This is a kid that wouldn't walk, and now he's riding his bike for 1/4 of a mile and dancing and playing Wii Dance with his games. In addition, he was less rigid and obsessive. So how do we treat mitochondrial dysfunction in autism? So commonly used treatments for mitochondrial disease have been found to improve both the core associated symptoms of autism in studies. So there have been double-blind placebo-controlled trials looking at carnitine, multivitamins containing B, antioxidants, vitamin E, CoQ10, and ubiquinol, and then folinic acid is another big one. So carnitine, as I said earlier, that's what helps shuttle fat into the brain, into the mitochondria for energy. It's also an antioxidant, what helps neutralize the free radicals produced by the mitochondria in the process of making ATP. So when mitochondria process our fat and our sugar to burn energy, they also produce waste, and that waste are free radicals. And those are basically electrons that are so inactive that they will steal another electron from the RNA, the DNA, the enzymes, the cell wall, and that's what causes damage to the cell. And so when we supplement with antioxidants, they can then donate an electron and make those free radicals stable. Now, the risk with carnitine is obviously it can cause diarrhea and some hyperactivity. So that's why working with a practitioner on how to adequately dose. Like, we typically don't start with the maximum dose. We slowly work up to the dose. So this is just for your reference. These are the doses for the mitochondrial cocktail in the literature. And then also hyperbaric oxygen therapy is another thing that can be helpful for mitochondrial biogenesis. So it helps the body make more mitochondria. And exercise is another way to help make more mitochondria. So this is just kind of a reminder. There are a lot of toxins out there. Anesthesia, for one thing, can be toxic in kids with mitochondrial disorders, can have regression after anesthesia, and so there are mitochondrial protocols that anesthesiologists should follow in order to keep your child safe for anesthesia, and that stuff is available, I think, on the Mitochondrial Disease Foundation website. So it's the Mitochondrial Disease Foundation website, and I think they have a handout in there where they have like sample letters that your doctor can send to the anesthesiologist, and you have to watch them. My son had his wisdom teeth taken out, and I'd given them all the stuff, but they were hanging lactated ringers, which is bad for mitochondrial, and so I had to tell them to take it down. And so just a lot of doctors aren't familiar with this, and so when you do go to hospitals, it's good to go to a hospital that's comfortable with mitochondrial protocols. So this is a picture of my kids doing HBOT when they were younger. That was something that helped my younger son go from like saying one word at a time. I think he had 50 words but wasn't putting words together, and basically this is what caused him to become the pain in the neck teenager he is today, because he just started talking in paragraphs and has not stopped. Now his brother, he went from saying one word at a time to putting 2 words together with hyperbarics. So with him, it's been just treatments that we've added along the way that have just slowly increased his speech. He didn't have the sharp trajectory like his brother. So hyperbaric oxygen can decrease brain lactate and improves mitochondrial metabolism autism, at least in studies of traumatic brain injury. It can also lead to producing more mitochondria. And in our kids, because they already have a lot of oxidative stress, you want to use lower pressures like 1.3 to 1.5, which is important to work with a knowledgeable person that works on hyperbaric and autism, because a lot of the centers will put your kid at like 2 atmospheres, and that could cause a regression because that's just way too much for these kids. So this is another important concept as well. So mitochondria also play a vital role in the central nervous system. The brain consumes 20% of our daily caloric intake, and the brain uses large amounts of that energy to maintain the ion gradients essential for neurotransmission as well as the plasticity and development of the brain. So treating mitochondrial dysfunction may help normalize EEGs in some individuals, and I've seen this happen. I've seen kids be able to be weaned on their seizure meds from treating their mitochondrial disorders. So seizures are another potential cause of speech delay in children with autism. So the human brain is composed of billions of neurons that communicate through electrical impulses, and those can be measured on EEGs. And so when a seizure occurs, when there's excessive neuronal discharge in the brain, and the location in the brain where the abnormal electrical activity occurs is how the patient is affected. And so if the seizure occurs in the primary motor area, that's where you see someone fall down and writhe on the floor like you see with a typical seizure, like a grand mal seizure. If it happens in the speech center, you may just see absence of speech. So it's not like you see any outward signs. And so we've had patients that have had EEGs during speech therapy, and you see abnormal electrical activity going on in their brain when they're trying to speak, and that's why they're having problems in some kids. So symptoms of seizures can vary drastically from patient to patient, and it's hard to tell. And there's things that kids with autism do that look like seizures that aren't, and then there's some things that they're doing that look like autism that are actually seizures, and that's where an EEG is really important to know. And so they can have odd sensations, they can have, a lot of them have aggressive behaviors, some of them lose consciousness and some of them don't, and many times seizures can be silent, subclinical. A lot of times we see staring spells. Sometimes when kids are holding their hands over their ears, that can be a seizure. So you think it's a sound sensitivity, but it might be a seizure. So really the EEG is the only way to know. So there are different types of seizures. There's partial seizures, and then there's generalized seizures. So the simple partial seizures, those are focal. That means they're in a small area of the brain. And in those seizures, awareness is unimpaired. So they're aware of what's going on. They may be unable to speak. They may have unusual head movements, blank stares. Their eyes might move to the side. They may feel like bugs are crawling on their skin. They may see things that aren't there. They may have pain or discomfort or nausea. They could just have facial flushing and sweating. That could be the sign of what's going on. Sometimes their pupils can be dilated, or they can have visual changes, or they may feel like a deja vu, or kids that have these like weird changes in mood or emotion. So complex partial seizures, in those seizures, consciousness is affected, but not always completely. And that can involve a kid just kind of behaviorally just arresting and stopping and staring off in space. They may make weird chewing movements. They may have non-purposeful movements of their hands, may have memory loss, which is a big problem because that can cause academic problems with academic performance because they don't remember what happened before or after the seizure. And then these can then later evolve into generalized seizures. My take-home message for the seizure talk is treatment is so important because even if it seems like it's just they're just staring off, it can evolve into something much more difficult later. So grand mal seizures can be life-threatening. So the generalized type of seizures, these are what you see with the grand mal tonic-clonic convulsions with the muscle rigidity and unconsciousness. And then sometimes patients will have atonic seizures where they have abrupt loss of muscle tone, their head drops, they suddenly collapse. And then there's myoclonic seizures. They're fast but breathe contractions with bodily muscles in which occur at the same time on both sides of the body. And then there's the absence seizures, and this is actually generalized. This is short loss of consciousness. There's staring spells, but they can also include oral or limb non-purposeful movements. The difference with absence seizures is there's no post-ictal state. So the post-ictal state is usually when after a seizure, patients are tired, and it can take them a long time. They may have to sleep for a few hours. And this is why a lot of times these kids that are having seizures at night that we're not aware of are sometimes hard to wake up in the morning. And it might be if you have a child that normally wakes up early and does great, but all of a sudden isn't waking up, maybe they had a seizure in the middle of the night. So absence seizures, I had one patient that was having, 5 an hour. But you had no idea they lasted like 3 seconds until we did an EEG, and that can affect, their cognition if you're having them that frequently. Okay, so epilepsy in young children with autism. This was a prospective population-based study of 120 individuals. In this study, they found 38% of the study participants had epilepsy. And of the study participants, 1/3 of them actually started before the age of 2. So what is the incidence of seizures in kids with autism? In the general population, it's 1 to 2%. Now, the studies range from 8 to 42, but with most estimate 25 to 30%. However, the prevalence of epileptiform activity, which is subclinical seizure activity, approaches 60%. So an abnormal EEG in 2/3 of individuals with autism, 1/3 of them have a normal EEG, 1/3 have epilepsy, and then 1/3 have subclinical discharges. So their peak ages where you see a higher incidence of seizures emerging, so ages 4 to 6, and then after the age of 10. If you have a boy or girl, there's an equal chance of having seizures. Interestingly enough, children that are taller are more likely to have seizures. And children with epilepsy tend to be more irritable and hyperactive, so those are some of the things that you see. And as seizures go up, sleep goes down. So if you have a child that was sleeping well at night and all of a sudden is having night waking, they could be having seizures in the middle of the night. And so interictal discharges. So this interictal EEG discharges are abnormal wavelengths not associated with seizure symptoms. That means it's abnormal electroactivity, but it doesn't quite meet the criteria for epilepsy or a seizure. Unfortunately, there is substantial evidence for both animal and human studies that indicate both seizures and abnormal epileptiform activity can contribute to cognitive impairment. And it's something that's not typically treated by neurologists. In this study of subclinical epileptiform discharges in children, they found 39% of the 69 test subjects had subclinical epileptiform activity, which was associated with language impairment. Another study in 2005 found 75% of the kids with autism had epileptiform activity. And then another study in 2006 showed 60%. So there's a lot of kids on the spectrum that have subclinical electroactivity, and you don't know it unless you do an EEG. And it's something that needs to be done every few years because it can be normal one year and then abnormal another as they get older. So subclinical seizure activity has been shown in this particular study to affect verbal. So it caused errors in verbal tasks if it was occurring in the left hemisphere, and if in the right hemisphere it was causing errors with nonverbal tasks. So there's clear studies showing that can affect your speech. So EEG's characteristics, can they predict the development of epilepsy in autistic children? So the results from this suggest that epileptiform activity found in children with autism is associated with later development of epilepsy. It can also cause poor attention and sudden language difficulties. 83% of the patients with frontal lobe epileptiform activity, epilepsy developed later. So I see frequently that this abnormal electroactivity isn't being treated in these kids, and I think these kids, might improve from treatment. So what are some of the possible causes of seizures? And so things that can cause seizure triggers are MSG in our food because it's high in glutamate. Cerebral folate deficiency, which I'll talk about next, can cause seizure disorders, as well as mitochondrial disorders, electrolyte abnormalities, and different things associated with liver issues. But these are the main ones in red are the ones that we find mostly in children with autism. So a seizure workup, we would do a physical exam as well as a neurological exam, an MRI or a CT if we suspect that there's a brain injury or tumor. And then standard laboratory testing where you're looking at their electrolytes, their kidney function, looking at their CBC to make sure there's no infection, kidney function. Lumbar puncture we don't typically do. That's something you would do like in an ER if you were concerned about meningitis or something else, like some sort of infection causing new onset of seizures. And then EEGs. So an EEG is an electroencephalogram, and it's a test that detects electrical activity in your brain using small electrodes attached to your scalp. Your brain cells communicate via these electrical impulses, and they're active all the time, even when you're asleep. And this activity shows up as wavy lines on an EEG recording. So this is a picture of my kids when they were little. I have a lot of patients that are parents, I should say, that are very nervous about getting an EEG. They're like, how in the world am I going to get my kid to keep these electrodes on? So this was when my kids were little. We lived in Florida, and as you can see, the way that their EEG was done there and here was completely different. Here, I was up all night for like 3 nights, making sure they weren't pulling out their electrodes. Here, when their heads are wrapped really well, so you could always ask them to wrap your child's head better. I don't have to watch them all night. And they're older and more mature, and they've had so many of them, they're pretty much used to it. So some of the pitfalls of EEGs, typically neurologists will order, the first thing they'll order would be a 45-minute test, which really doesn't tell you a whole lot. It's a snapshot in time, and a lot of these kids are having seizure activity at night or abnormal electrical activity at night, and so that's going to be missed. Even 36-hour EEGs can miss seizure activity. So we have some patients that have grand mal seizures, but they've just never been captured on an EEG. So it does have limitations, but it's still an important thing to do. Some kids that are more difficult to treat, we might consider doing a Spect Scan. So a Spect Scan is a nuclear image test, and where they measure blood flow. It's a radioactive tracer, so it's not something we do in most patients, just difficult to treat kids, like we did this in our children. So when blood flow is increased to an area, the brighter area lights up on the scan. And so here is an example of an area of increased blood flow that could be a seizure focus. And we found something like this in my younger son when he was like 2.5. So during a seizure, more blood flows to the area when the seizure comes from. And this can be valuable for finding the seizure onset zone. So some of the treatments for seizures are nutritional supplements, medications, steroids, IVIG. Sometimes the ketogenic diet or the modified Atkins diet can be helpful. Hyperbaric oxygen therapy, a vagal nerve stimulator, that's like, if your kid fails multiple seizure meds, because that's a surgical procedure and surgery. So this is a study done by Dr. Fry and Dr. Rossignol that found good evidence for valproic acid, lamotrigine, and levetiracetam as good, or Keppra is the other name for it, have been found to be the most effective seizure meds for treating kids on the spectrum. And they also found evidence for the ketogenic diet, the modified Atkins diet, immune modulation like IVIG, and neurofeedback. These are some of the supplements that have been found to have some anti-seizure effects. So melatonin, which is great for helping our kids sleep, also has some anti-seizure effects. Taurine, which is calming. A lot of these kids are hyperactive, can be helpful. Omega-3 fatty acids. Magnesium, calming. So a lot of these things are very calming, except for maybe like B6 and L-carnosine. So this is a really important case series. This is another take-home message for you. This is a study done by Dr. Fry. Okay. There were 22 patients in this study. 91% of the patients in this study had a speech or language disorder. And after they saw Dr. Fry, they had abnormal electrical activity on EEG that did not meet criteria for a seizure disorder. And he did a trial of seizure meds. 70% of the patients that received an anti-epileptic drug responded robustly. And then another 10% responded after the dose of the medication was increased. So, this is a huge study and very important. So, because as I showed you from previous slides, that seizures, abnormal electrical activity can cause language problems. So this is a study. This is not children with autism. So in this study, they used very, very high pressures. I wouldn't recommend pressures this high, but they were able to use hyperbaric oxygen therapy for 45 sessions in neurotypicals, and they were able to get a lot of patients off their seizure medications. It was effective in 82% and significantly for 68%. And so some were able to discontinue, and others were able to reduce their dose. So cerebral folate deficiency, this is the thing that's should be front page news because it's so huge in this patient population. So we're just going to talk about different types of folate, and some of this stuff I'm going to skim through because it's not as important, but it's just there for your information. So folate, the take-home message for this slide is folic acid that you get in your vitamins and in your fortified foods is inactive. And it also inhibits folate from being transported into the brain because it blocks the receptor. That's your take-home message for this particular slide is folate in your vitamins and your fortified foods is not good for your kids. So MTHFR, very common genetic variant we see in our patient population. It's something we test for because it's treatable. 800 micrograms a day will help bypass, folinic acid will bypass this genetic defect. It's a standard test that you can get done through LabCorp or Quest. So examples of activated folate. So folinic acid, which is the common form of folate that we use, it crosses the blood-brain barrier for the reduced folate carrier, and it's biologically active. It doesn't need to go through MTHFR. So if your child has the MTHR defect, it won't matter. And so that's why it's a benefit. It's very versatile because it helps. It's involved in the folate pathway, which is involved in DNA and RNA and neurotransmitter synthesis, DNA methylation, which determines whether DNA is turned on and off. And then it's also critical for the detoxification pathway. And it avoids the folate trap. So when you use the other form of the 5-MTHF, unfortunately that sometimes can lead to a folate trap. So this is 5-MTHF. The other, the prescription name for it would be Depilin. And so some patients will take this and some people do well on it. It hasn't necessarily been studied for treating cerebral folate deficiency, but it is used by some patients. So it crosses the blood-brain barrier through the folate receptor 1, which can be blocked by inactive folate, and also by autoantibodies to the folate receptor 1. So another reason for why we don't necessarily go to this as the first choice, and I think it wasn't used in the studies. So it methylates B12 to make B12. And so if it can't be used, it can create or worsen folate excess, leading to the folate trap. So why is activated folate critical for brain function? So it's critical for homocysteine metabolism, detoxification, DNA methylation, which turns DNA on and off, neurotransmitter synthase, so your serotonin, your dopamine, your epinephrine. It's important for synthesis of your nucleic acid biosynthesis and critical for fetal and neonatal brain development. So folate is transported into the brain through the reduced folate carrier and the folate receptor alpha. So the blood-brain barrier is a physical barrier separating the blood and the spinal fluid. And basically, in order to get through the blood-brain barrier, there's a system of cellular transport mechanisms. The blood-brain barrier protects your brain from things getting into there that shouldn't be there. And so the blood-brain barrier helps maintain homeostasis. And so we're going to be focusing on receptor-mediated transport through the blood-brain barrier, which is right here. So the reduced folate character is present on every member of the cell, and it modulates delivery of reduced or active folate into the cell. And polymorphisms that are associated with this are associated with higher incidence of autism. I'm going to skip this. So the folate receptor 1 is found in the choroid plexus of the brain. So the way that folate is transported into the brain is it binds to the folate receptor in the blood-brain barrier, and then it's transported by the reduced folate carrier. And this process is the other take-home message. It's ATP dependent, meaning it requires energy. So if you have mitochondrial problems, you can have problems getting folate into the brain. So cerebral folate deficiency is a neurometabolic syndrome associated with low activated folate in the brain with normal folate levels in the blood. And then it is a progressive neurological disorder that is treatable and potentially reversible. And multiple studies have shown an association between cerebral folate deficiency, Rett syndrome, and autism in some children. So the causes of cerebral folate deficiency include autoimmune, so autoantibodies to the folate receptor, mitochondrial problems, and then different genetic defects like severe MTHFR. So folate receptor 1 antibodies are associated with cerebral folate deficiency, low functioning autism, and Rett syndrome. They block the antibodies block the folate receptor 1 in the blood-brain barrier so that folate cannot get into the brain. And without treatment, the concentration of autoantibodies increase over time. So this is a study with 25 patients with early onset low-functioning autism. In this study, the patients had spinal taps. We don't typically do this in our patients, but this is a research study. Their blood levels of folate were normal, and then their activated folate was low in the spinal fluid. 19 of the patients were positive for folate receptor antibodies, explaining why they had low levels of methylfolate in the brain. And they treated them with oral folinic acid, which is activated folate, which led to normal folate levels in the brain, partial or complete clinical recovery after 12 months. That's the other take-home message. Treatment is not just like for a week or a month. Sometimes it can be for years. So I've had patients that their EEGs have normalized, but it took like 2 or 3 years. So mitochondrial dysfunction and CFD. And so mitochondrial dysfunction in the choroid plexus, if there's not enough energy, then it might be difficult for the folate to be transported across the brain. And so interestingly enough, folic acid is one of the treatments that are used often in mitochondrial cocktails. This is a study. Basically, the take-home message from this study is this patient with a mitochondrial disorder did not have autoantibodies, so the test was negative. She was still treated with folinic acid, and she developed full control of her epilepsy. And they believe that the cause of her low folate levels were failure of ATP production. So because of her mitochondrial problems, she couldn't get activated folate into the brain. But treatment with folinic acid still led to improvement. So what are the features of cerebral folate deficiency? Let me go to this one. Okay, a small number of children develop normally during the first month of life. Some regress around 4 months, some regress later. There can be late onset, early onset, so it's not always the same. And 20% of children with cerebral folate deficiency develop autistic features. Many children with cerebral folate deficiency have speech delay. Some develop hearing and vision loss, and 1/3 of them have seizures and are untreatable. And many develop moderate to severe mental disability. It is a spectrum. Okay, the prevalence of autoantibodies. This is normal prevalence. So in neurotypical kids, 2 to 3%. Adults, like I am positive for them, so it's something we can develop over time. But I didn't have them when I was a little kid. My brain was developing. So this study showed about almost 78% were positive for folate antibodies with kids with autism in this study. And in this study, they looked at 76% of the children, 75% of their unaffected siblings, fathers, a high percentage, mothers, and then normal controls about 30%. So having a mother positive for these antibodies can affect her child in utero. And so one of the prevention slides that is further in your handout, it can be important to identify this before having another child, especially if you already have one kid with autism, and being treated for that if you plan to have more children. So milk also causes, so the antigen is basically found in milk. And so when you take milk out of the diet, the antibody levels go down. And when we add it back in, some patients, they go up, and some they go up even higher than they were before. So milk-free diet is really important for treating cerebral folate issues or antibodies. So testing. So if you have a child that has insomnia, developmental delay, you want to test them. And so there's a test through Iliad that measures the blocking and the binding. And even when these tests are negative, I still usually do a trial of leucovorin because a lot of times kids have mitochondrial dysfunction. So this is just an example of a testing. And this child was negative for binding and blocking. However, in the brain, they had very low levels of folate. So just because the test is negative doesn't mean that there aren't low levels in the brain, especially if they have mitochondrial issues. I'm going to skip that slide. Obviously, the lumbar puncture is the gold standard. We don't really do that in kids because, it's better just to do an empirical trial of the leucovorin. And so the CFD is also associated with epileptiform activity, seizure issues, atrophy of the brain, atrophy of the optic nerve, so why some kids have visual issues. So the treatment for this is folinic acid at 1 to 2 milligrams a day, divided into 2 doses. A 5-MTHF could work, but it hasn't been studied, so we typically use folinic acid. So in studies of children with both autism and cerebral folate deficiency, treatment with oral folinic acid resulted in improvement ranging from partial improvements in communication and attention and stereotypical behavior to complete recovery of both neurological and ASD symptoms. Now, obviously, the younger you start, the better, because it's really important for development of the brain. But even if you start later, there's still hope. My kids were 8 and 10 when we found out about that they were positive for autoantibodies, and their EEGs normalized, and their speech got better. So it's always important to treat this even when they're older. Okay, and this is another study. 4 of 7 of the children, 57%, demonstrated some improvement in cognitive and motor skills, social interaction, communication, and a reduction in the frequency of seizures with folinic acid treatment. So we're going to skip this. So this is a recent study done by Rainmakers. He's kind of the person that led this issue. He's a great researcher, and in this study done in 2019, the test subjects had blood draws where they looked for different trace elements and things that could be deficient, and so he measured both binding and blocking and folate antibodies in the test subjects, autism and their parents, and that's where they found the high incidence in the children, almost 76%, a high percentage in the mothers as well as the fathers, and only 3% in the healthy controls. So they treated the nutritional deficiencies, and then if the folate antibodies were positive, they treated them with high-dose folinic acid up to a maximum of 50 milligrams. In this study, the results showed the controlled children remained unchanged. The test subjects treated for vitamin deficiency in addition to the folinic acid, their CAR scores declined to a mean of 34.5, indicating mild to moderate autism. The CAR score dropped below 30%, which is consistent with absence of autism symptoms in 17 of the 82 test subjects, which is 20%. So the majority of those 14 out of the 17% of the subjects whose CAR score dropped below 30 started treatment before the age of 5. So that's why it's really important to start the treatment as early as possible, but it's still never too late. And then also the other thing that's important is if you're having more children, is consider avoiding dairy during pregnancy and while breastfeeding, and treating the parents, both the father and the mother, during postnatal and try treating the child postnatally with high-dose folinic acid. Just because the studies show there's a high incidence of the antibodies in siblings. And I'm going to skip this. Let's see. Am I out? Okay. Thank you. Let me go to the end. So also in here, sorry, I just have too much stuff I wanted to share. But now you have all this information for later, and I think most of the information's on the slides. But we also, where is this? So these are all the medications that have been shown in studies to be helpful for autism, the ones that are level A or have the highest level of evidence. And then these are the supplements that have been shown to help improve speech. And the supplements don't have as great as studies just because people aren't making money off of them, so there's not been as many studies. The big caveat and why it's important to work with a practitioner is that most things that help with speech are activating. So if you have a kid that's hyper, they're going to become more hyper. So a lot of times we try and add in calming stuff in addition to the activating stuff for speech if we have a kid that's really hyper. And sometimes they even need a medication to help with hyperactivity. So for example, one of the drugs that's really helpful for speech is Propranolol. It's a beta blocker. So this can be helpful for kids that are hyper and have attention issues and anxiety. And sometimes I'll add this in before I add in some of the other treatments because it's also calming. So it helps that fight or flight thing that these kids have, the elevated epinephrine and norepinephrine. And then this is Namenda. This is also calming. So some of them are calming. And then like cyproheptadine, this is good for kids that have a poor appetite. And so sometimes you determine your treatment based on other symptoms. And just the take-home message is never give up hope that new things come out. I am still learning new things. My kids are still, making improvements. Like my older son, this past year, I added in another treatment, and he no longer needs an aide at school. And he goes to a high school where he changes classes and has a locker. And I never thought that this would happen. And so, he's telling me about things that he dreamed back when we lived in Florida and he had pandas. It's amazing. So God bless you all, and I hope you guys find the answers you need for your kids.
Thank you so much, Lanier.